Afternoon, or maybe good morning, everybody, depending on where you're sitting today. My name is Brian Kansian. I'm the Business Development Manager here with Foundation Software. We're going to just hold up here for a few more minutes while we have some people just getting signed in. We've got a lot of people registered and only about 40 online right now. So we're going to give it probably 2 or 3 minutes and we will pick up. So stick around and we'll be back with you shortly. All right, it is just a couple minutes after 12:30 here in the Eastern time zone, so we're going to get started. I just want to welcome everybody. Thank you for joining today's webinar, Best Practices for Reducing and Controlling Healthcare Costs. My name is Brian Kansian. I'm the Business Development Manager here with Foundation Software. And today we're going to be talking about healthcare costs as well as strategies that construction employers such as yourself can take to offset a lot of these changes. We'll touch on some of the key factors driving these increases in costs, how you can potentially reduce those costs, as well as smart ways to fund health plans. And you'll have an opportunity at the end of the presentation to get some of your questions answered here by our experts. So before we dive in, I just want to go through a few housekeeping items. All of you are in listen-only mode and are muted. So when you have questions, we encourage you to ask those in the questions box. If you look at the top of your go-to screen, there should be a little icon with a question mark. That opens up your control panel and you should be able to submit your questions there. We will get to those at the end of the presentation. We're not going to go through those live during the presentation. So please feel free to get those submitted as we're going along and as those questions pop into your head. Also, everyone will receive a recording of the session once it is finalized. So you will be emailed a link to that. So without further ado, let's go ahead and get into it. See if I can get my screen moving here again. So our speakers today, we have myself, Brian Kansian. I will be moderating this and going through the questions at the end of the presentation. With us from ABC Insurance Trust, we have Adam Bonsky, and we have Dan Burke, who is the Vice President of Corporate Benefits with the Turner Industries Group. Not to be confused with Turner Construction. I hear it's commonly mistaken, not who we have with us today. So guys, I'm going to turn it over to you. And like I said, we'll address these questions at the end of the session. So take it away.
That's good. Well, I think we start with a couple of introductions and then we'll dive in. So again, I'm Adam Bonsky, the CEO and president of the ABC Insurance Trust. We are a part of the ABC family of organizations that support construction companies across the country. I've been in employee benefits now for about 32 years, working for large banks, insurance companies, third-party administrators, and most recently with the ABC Insurance Trust. For about half of those 32 years, I've specialized in working with construction companies and their benefits almost exclusively. And so with that also comes the knowledge around the Davis-Bacon Act and prevailing wage rules. So myself and my team are all experts in working with construction companies and their benefits, whether that be healthcare plans or ancillary plans, retirement plans, whatever the case may be. So with that, I'll pass it over to Dan.
Great. Good morning, good afternoon, everyone. My name is Dan Burke. I'm the Vice President of Corporate Benefits with Turner Industries Group. We are a proud ABC member, and we are headquartered here in Baton Rouge, Louisiana, but we operate across the U.S. in industrial contract work and construction, focused on the oil and gas and energy sector. Like Adam, I've been in the employee benefits world for 30 years. The last 18 of them have been here at Turner. Prior to that, I was with a financial services firm, large national, international firm. And before that, an engineering company that also dabbles in a bit of construction. And certainly look forward to our conversation today, and we hope that you find it useful.
So thank you to the folks at Foundation Software for giving Dan and I this opportunity to speak to you today. Dan and I have a fair bit in common, we've learned over the last year or so. And it's not just our hair-free approach to life, if you will. Although, Dan, I hear UCLA has come up with a new protein that's going to cure baldness, right? So
really,
maybe the next time we give this presentation, we'll both have full heads of hair.
That's it. Yeah, I look forward to that.
Well, the other thing we have in common is we both have a passion for helping contractors around the country with their employee benefits, particularly their healthcare, which is a really big pain point for a lot of contractors right now. So Dan and I have been doing the roadshow for many months and plan to continue that roadshow through next year. So you'll see us at other events with other organizations. We did a webinar with ABC earlier this year. We had 200 people sign up for that. We have, I think, 200 people signed up for today. So thank you all for attending. We're going to have to talk pretty quickly because there's a lot of content to cover. So Dan and I are going to just dive right in. Next slide covers our agenda. And so the first thing we'll talk about is the state of healthcare today. This section might get you all a little riled up, a little bit angry, but Dan and I would just say, please don't shoot the messenger. We do hope afterwards you at least have a deeper understanding of what things are causing the healthcare costs to rise so quickly, and what things you can do to contain those costs as an employer. About 60%, according to the Kaiser Family Foundation, about 60% of the construction industry's workforce is on a self-funded plan. So we're going to talk about self-funding and how important it is in being a linchpin to gaining more ability to contain your costs in your plans. And then we'll dive into medical cost containment and pharmacy cost containment. If any of you look at the claims for your plans, 90% of your claims come from these two areas, from hospital costs and pharmacy costs. And that 90% is driven by just usually 10% of your people. So this is an addressable, fixable thing, but it does take some work and diving in on that 10% that drives 90% of your costs through hospitals and pharmacy. And last, we'll talk about member advocacy and experience. This is important in the sense that you don't want to degrade the level of service your employees get, but you do want to help them find high quality, low cost providers. So we'll talk about care navigation and some of the financial advocacy you can do for your employees to help them bring down their own out-of-pocket costs. So with that, next slide. Now remember, Dan and I are just the messengers. If this were a drug commercial at night, I would say, warning, this information might cause anger, depression, aggressive pounding of the desk, heart palpitations, whatever it is. We are going to share some facts that are frustrating, but keep in mind, 60% of everybody on a health plan across this country gets it through their employer. So we as employers have a responsibility in trying to fix what's going on in healthcare. So next slide.
Adam, also, you can enrage to engage, right? That's the key. The information may get you mad enough to take action and listen to some of the suggestions we have.
Yeah, amen to that. I mean, none of these, I think we can agree, Dan, are easy. But when you're looking at the kind of renewals you're getting right now and have been, and the state of things just keep trending up, you've got to change, right? So, so next slide.
So this slide is a shocking piece of information comparing 2000 to 2024. As individuals, I think we've all become somewhat conditioned to expect regular increases in health costs. But as you can see here, it's greatly outpacing inflation or wage growth. And the other alarming piece is the percentage of employers offering coverage. In 2000, it was 69%. It's down to 54% now. And the cost of average cost of family coverage has quadrupled, more than quadrupled. One important point here is that average cost does not include out-of-pocket costs and deductibles, changes in deductibles, plan changes. That's purely the cost. And as you look at costs nationally, Adam and I had a conversation yesterday about some of the different data sources and the consulting houses looking at cost. One that I use quite a bit is the PwC Behind the Numbers report, has the inflation at 8.5% for this year, which is significantly higher than it has been in prior years. So, you know, this is a shocking slide, and one that, to my earlier point, could enrage to engage.
Yeah, as Dan said, that's just the premium cost, not the out-of-pocket. And another study Dan and I talked about yesterday is what Mercer just came out with, and they said that this renewal season is setting up to be perhaps the worst renewal season in 15 years. And they're also I think their projection was a 9% trend, which means many employers are going to get double digits and maybe even to the 20s and 30s, you know, depending on how your plan is running. So next slide. So the RAND group, and Dan has a fair bit of familiarity with the RAND group, and he'll talk about that in a second. But the RAND group is a nonprofit, nonpartisan research organization that works on driving policy across the country. And one of the policy areas they're strongest in is healthcare. And so they recently did a study on hospital pricing, what those strategies look like for hospitals, and how hospital pricing impacts employers who are providing healthcare. So we're going to keep getting you upset. 1/3 of Americans must take out a loan to help pay for their medical expenses. 38% of adults enrolled in high deductible health plans either skip or forego recommended medical care. So consumer-driven plans have lowered the premium costs, but at the same time, they've increased the out-of-pocket, and employees are skipping care because that deductible is so high. So it's not working quite as intended, going back decades now. 52% of insured Americans feel stressed out about medical bills and say that stress impacts their mental and physical health. I don't have medical bills myself, at least at the moment, and I feel stressed about it. Yeah, so it's just an overall feeling of this is going in the wrong direction. Since 2000, deductibles have gone up 473%, and premiums have gone up 355%, while, as Dan pointed out earlier, wages have only gone up 178% and normal inflation up 167. We're going to show you a chart for this just to show how dramatic that difference is. And then last but not least, we're going to dive into Medicare. So employers, on average, employer plans, I'll say, on average, pay 254% of what Medicare pays for the same services at hospitals. So some states like Florida and Georgia are 345% on average above what Medicare accepts for the same services. So obviously that's a ridiculous difference, and we're going to talk about some ways you can start to attack that. So Dan, you've got some experience with working with the RAND group yourself at Turner.
Yeah.
And on the next slide, we can probably move to it. You can see clearly how different these lines are, sort of how much they're diverging.
Yeah, and you see there the 473% increase in deductibles. That one is just outrageous. And when we talk about costs, generally you think about premiums, but that deductible is just a form of cost shifting, right? From one entity to another. As it relates to the RAND study, I had the good fortune several years ago to be asked to participate in contributing claims data for our organization to the RAND study for their broader overview nationally of health costs. And this was through my affiliation with the Houston Business Coalition on Health. And that was spearheaded by the Employers Forum of Indiana, you know, a coalition there in Indiana, very forward-thinking organization. And it's important to note that Adam mentioned it earlier, but RAND is an independent entity. They don't have skin in the game here. They're not taking sides. And they're just simply providing information on the health costs nationally, specifically hospital costs. And they've broadened that to include ASCs and some other facilities as well. But it's a reputable study.
All right.
Let's jump to the next slide. So as we look at costs nationally, the RAND report will show you state by state what the benchmarks or what the costs are as compared to Medicare as a benchmark. You'll see Texas there. My company has a lot of employees in Texas, Louisiana, Alabama, Florida, 344%. And you know, the argument that employers should be making, and we are not saying that we want to pay Medicare rates, because we know that health systems and providers have trouble getting by on Medicare reimbursements. And there are a number of reasons for that. There's a large administrative burden that these entities carry. They also have liability insurance, medical malpractice expenses to be worried about. But I would make the argument that if we look at Florida, 344% of Medicare seems like a bit much. Maybe 120%, maybe 150%, maybe 175 is appropriate. But that's a conversation that we can have, you know, with our partners, healthcare partners in our communities that we work and live in, and with our vendors, whether you're with a BUCA carrier or with a TPA. These are things that employers should really be pushing for, is more transparency as it relates to costs. Adam, any insight there?
No, we'll dive into the cost side of this equation in a similar map in a few slides. But right now we're just focused on how much over Medicare employer plans are paying for the same services.
Right. Next slide. So this really gets to the point on cost shifting. You know, Adam, you can kind of chime in here, but it's really just moving costs from the employer responsibility to the employee. And as we've looked at high deductible health plans since their inception back, I guess 2000, early 2000s, when they first hit the market, the idea was that that would increase consumerism in healthcare. The problem at that time was that the information about the different costs for care was not available. So in my view, I think consumerism has been something of a failed experiment in healthcare so far. Things may change going forward, but you know, based on the data that we're seeing from the RAND report, these things haven't slowed down any.
There are a lot more tools out there than there were 10, 20 years ago to shop for high quality providers at a reasonable price. There's a lot more solutions now around, obviously, medications, and we'll talk more about that to find lower cost ways of sourcing them. So on the next slide, speaking of, many of you have maybe heard about PBMs. President Trump has brought up in many of his recent speeches about the pharmaceutical industry and PBM as being a big part of the problem from his point of view. So a PBM is a pharmacy benefit manager. And so as we're saying at the top here, they generally are a TPA, so a third party administrator as it relates to pharmacy claims. And so they're not worthless. They provide value. There's many things they do in the value chain to help provide medications to covered individuals across the country. So they're handling claims payment and claims adjudication, reporting eligibility, they're handling the billing and customer service. But over time, they've gotten quite a bit of control ceded to them over the distribution of drugs. And with that control, they've used it to gain quite a bit of power over what the pricing is that plans pay for medications. And so I'm not upset that they have a business and add value, but is the amount they get paid appropriate based on what they do? And is the payment model appropriate based on what they should be doing for health plans and individuals? So I think the initial intention of PBMs is great. Let's get medications out to everybody in a cost-effective way. But that increased control has been a problem, and their incentives aren't always aligned with your incentives as a plan or as an individual. And lastly, many of the large insurance carriers like United Healthcare and Aetna and Cigna, they own the largest PBMs in the country. And so we'll look at what that concentration looks like here in just a minute. On the next slide, as we've suggested earlier, a lot of your costs that come from hospitals, hospital services, and from medications come from just a few of your employees. So as it relates to drugs, let's call it 65% of your drug costs are driven by only about 7 to 10% of the prescriptions in your plan. So again, this is addressable if you can attack that 7 to 10%. The top 100 drugs in the United States, the revenue for all those drugs exceeded $240 billion in 2023. Sorry, guys, I just had a little glitch here. And as I said earlier, PBMs don't necessarily have incentives that are aligned with keeping your costs down. So I think that's something to think about as you're looking at PBMs is what is their payment model and is it aligned with keeping costs down for my plan? If they're getting paid on what I would call an opaque spread model, where they're getting some markup on the drugs that they're providing to you, it's really hard for you to know what that is or to know if it's reasonable. And then there's also a lot of question right now about tariffs too, and what impact tariffs will have on the cost of medications. Most generic medications are actually manufactured overseas and then brought to the US. So what's going to happen with those medications? And specialty drugs are really what are driving most of the RX spend these days. Your generics are usually just a few dollars, but the specialty drugs are what are really driving a lot of the uptick in spend, and what's going to happen with those as well as tariffs kick in. So a lot of unknowns. We'll see what happens literally in the coming months. Next slide. You can see here the concentration of PBM revenue amongst just 3 ginormous, if you will, PBMs. CVS Caremark, owned by Aetna, Express Scripts, owned by Cigna, and Optum, owned by United Healthcare. So a good 80% of all the distribution of medications that goes on in this country happens across just 3 companies. And those companies will tell you that they don't charge an admin fee, but of course they're making money. And so it's a pretty opaque model, unfortunately, and usually the money they're making is on the markup or on what some people might call the spread over what the manufacturer charges for the medication and what the plan pays for the medication, or your plan pays for the medication. There's also, and we'll talk about it later, a massive problem with how much we pay for medications in the US compared to what other countries pay for the same medication. So we'll talk more about that.
I think you made an important point on the last slide that fed into this one, and that's that, we're not saying that PBMs are evil. They provide a service to self-insured employers that we could not provide on our own, getting drugs to thousands of people across the country and doing so very efficiently, by and large. But I think with the negative press that the PBMs are receiving, we can lose sight of that. From an employer's perspective, I've always found pharmacy benefits, not PBMs, pharmacy benefits to be something of a shell game. You know, drugs are marked up or there's spread pricing introduced with rebates going back to the plan sponsor, and we'll jump into some of that in a little bit. But transparent PBMs are becoming more popular on the market, and they're not the big three that you see on this wheel slide here. There's some of the smaller ones like MedImpact and others. But at the end of the day, you have to be able to provide benefits to your population that you're comfortable with. And sometimes the smaller players in the PBM market have a tough time with that. And at the same time, they can have a hard time delivering the financial results that sizable employers are looking for.
Yes. So next slide. I think we're going to talk about some of these specialty drugs, and Dan will touch on rebates too.
Yeah, so if you watch TV in the evenings, you see these drugs, right? Humira. Humira is the most profitable drug of all time. That was recently a distinction that they received. Stelara annual cost is $156,000. Many of us sponsoring employer plans are familiar with the Ozempic and the other drugs in that GLP-1 classification. Then you got Rinvoq, who runs ads seemingly around the clock these days. And you know, when you look at these are the drugs that are not only high cost, but they also drive rebates back to your plan. And the rebates, employers should be sharing those rebates with their employees and plan participants, whether in the form of lower deductibles, lower premiums. That should be a component of plan management. And the other piece that you don't see here as well are some of the cancer drugs that are miracle drugs, you know, saving people's lives, extending people's lives beyond what we could have dreamed of 20, 25 years ago. But there's a cost that comes with that, and a cost that you have to budget for as an employer on a self-insured plan. Any thoughts that I missed there, Adam?
No, that's spot on. I think I've got definitely some comments on the rebate slide that's coming up next. So.
Yeah. Yeah, rebates, they do matter. So back to my point earlier about transparent PBMs versus the big three PBMs. The big three PBMs will be able to offer you significant rebates, and that will help you lower your total cost of care, which is your ultimate objective, which can be shared between the company and your plan participants. But this is a really good illustration of what rebates, the impact of rebates on a plan. So you go from $78,000 down to $54,000 with that $24,000 rebate, and that makes a difference. You know, that's a big piece of the puzzle for employers these days. I'd love to get to a place where rebates didn't have to be a consideration, where you could get to a place where you're looking at just bottom line costs, but it is part of that shell game that I referenced earlier that you have to track. And the word Adam used earlier, opaque, is probably the best way to describe pharmacy benefits from an employer perspective. Adam, what are your thoughts?
Yeah, I mean, you know, I would rather not get a rebate and just sell me the medication at the price before the rebate. So there are PBMs, and as Dan pointed out, it could be a lot of the smaller ones who are trying to be innovative in the pharmacy benefit management space that will work with you to just get the medication to you at the lowest cost possible. You know, when I think about rebates, it's like, well, that means I got to wait a year to get my money back, right? And so the main theme I would leave you with, and I think Daniel would agree, is when it comes to pharmacy or medication, source the medication at the lowest price point possible. You know, medications are not like providers. Providers are not all created equal. Some are high quality, some are low quality. You know, there's a lot in the middle. There's a lot of variance in what you can get from doctors and specialists in the hospitals. But with a drug's a drug. So there's no point in, if you don't have to, paying any more than you should for a particular medication. And we'll talk about ways that you can obtain medications through your plan at much lower rates through alternative sourcing. But anyway, this is an important conversation to have with your broker and with whoever your PBM is how do you handle rebates? And is there a way we can skip the rebate process and just pay the net cost up front? So
yeah. The other piece before we move off of pharmacy that is getting a lot of attention these days is 340B drug pricing. The 340B program allows for health systems and hospitals to acquire drugs at a steep discount, with the intent being that those are used for the uninsured, the indigent population, underinsured, underserved communities. Certainly an important piece of the healthcare puzzle, but what has happened is that some of those health systems and hospitals have marked those drugs up and they're providing them to commercially insured patients, which means that those of us that are sponsoring healthcare as employers are paying a marked up version on those costs. So there's a lot of talk nationally about potentially, there's talk in Congress about addressing 340B abuse. I know in Louisiana, there was conversation in the last state legislature about introducing some law on addressing 340B. That got shot down, but I would imagine it will resurface here and in other places as well.
Yeah. Okay, so next slide. One last note on the pharmacy side of the problem in healthcare is that there's a lot of shifting going on in claims. So it used to be several decades ago that most of your claims in your health plan were coming from medical, primarily hospital spend. But as you can see in this slide, little by little, that trend is shifting where more and more you're spending a higher percentage of your claims cost on pharmaceuticals. And that has a lot to do with these specialty medications and cancer treatments that Dan mentioned earlier that are really driving up the cost. So the good news, you could say, is that there's innovation happening with pharmaceuticals that are curing diseases or mitigating them far more so, or even eradicating them from a gene perspective. But the research that went into creating those is hugely expensive, and the pharmaceutical companies are going to recoup that, especially in that first 7 years or whatever that patent window is. So the good side is innovation. The bad side is that innovation is very expensive and it's going to be borne by employer plans and individuals. Over time, this should reduce what you spend on hospital costs because people using medications don't need to be in the hospital as much. But obviously, if they both go up, then we're in big trouble. So this is definitely a trend worth keeping an eye on, and also keeping in mind again that all providers are not created equal, but medicine's a medicine. So always try to source medications at the lowest price point possible. We'll talk more about that. Next slide. I think this is the last doom and gloom, if you will, but it is pretty telling. So Kara, if you can just fast forward through the bullets on the screen here. This is what the major carriers are telling us, or we're seeing in the news right now. United Healthcare is talking about the loss ratio spiking from 24 to 25, up 88%. Right? Cigna is seeing a huge spike in their RX and cancer stop loss claims. So they're expecting a big increase in their stop loss exposure in 25 and 26. Blue Cross of Michigan posted a $1.7 billion operating loss in 2024. Blue Cross of Massachusetts recorded an operating loss of $400 million in 2024, the largest in their history. Voya is seeing their loss ratios soar. Sun Life is seeing their loss ratios go up after a $100 million loss in their stop loss business. So you see the trend here. The carriers are getting whacked with higher claims, and that is going to get passed through to the customer. So we all have to continue to look at ways to be inventive and aggressive around cost containment rather than just sitting and taking it, if you will. So next slide, unless Dan, anything else to add there?
No, I would just point out that those of us that are self-insured today, we're all having difficult conversations with our stop loss vendors for those of us that carry stop loss. And it's been that way for the last 3 to 5 years. And a decade ago, I remember recommending that we discontinue our stop loss, kind of self-insure it. I would never make that recommendation today with the developments in the medical technology that we've referenced.
So next slide. So we're going to talk about self-funded plans, and the most important thing to consider here is the two things you gain the most of in moving towards self-funding is transparency and control. Those are the two key words to keep in mind: transparency and control, which is what you don't have when you're in a fully insured, or even in some cases a level funded program through a large carrier. The linchpin in getting a lot of these cost containment measures in place that we're going to talk about is moving yourself out of fully insured and more towards that self-funded end of the spectrum. And self-funding sounds scary, but we're going to talk about how actually in self-funded plans you can cap your risk, right? Just like you do in fully insured. So it's actually partially self-funded is what employers are, unless you're a giant company like Turner or others that have thousands of employees where they can purely self-fund. So let's talk about that. You are going to need more expertise on staff or have an advisor who is comfortable with self-funded arrangements so that you've got the right level of expertise on your team and the ability to handle that transition from fully insured to self-funded. So on the screen here, we're showing you two options. There's the health plan sort of big insurance option or the partially self-funded one. And on the left-hand side, it's all locked up in a box, right? So you don't have any or very little ability to influence claims or manage claims. You can't change out the component parts. If you don't like the way the PBM is performing, you can't switch it out. It's all bundled in. You have little ability to drive strategy on how you're going to reduce claims. And you can't determine who you're pooled with. You're pooled with whoever the carrier thinks you should be pooled with, right? So maybe you're not getting pooled with the best risk and it's hurting your renewals. On the other side of the equation, partially self-insured, you're unlocking the box. And so now you can see that there are basically three different types of cost. Your medical claims and RX claims, which is usually the biggest part of the pie, and then your stop loss insurance and your administration. So generally we call the claims cost variable cost, and we call the stop loss and administration fixed costs. Those are the costs you pay every month no matter what. And then the claims, of course, if you're paying claims as you go, can vary from month to month. So you do in this scenario have the ability to manage your claims and see what's happening and train your employees or make sure they're compliant with their care or push preventative care more so because you see who's using it and who's not using it, or who's using the emergency room too much so, or whatever the case may be. You get more transparency and therefore more ability to do something about the cost. You can negotiate your stop loss premium from year to year. You can negotiate the administrative fees that you pay to service your plan. So transparency and control is the name of the game here. And that, if you're ready for it, is where you're going to start to be able to dial the cost down, right? And put cost containment measures in place. It's your plan, it's your data. So whatever partially self-funded situation you go into, you make sure that whoever you're working with assures you that you have full access to your data whenever you want it. So Dan, anything else you want to throw in there?
I think you covered it pretty well, Adam. The only thing I would add is that the way I like to look at it is fully insured, you're essentially buying an off-the-shelf product. It's delivered, or you're buying a home as is. You get what you're buying and that's it. You don't have the ability to tweak it to meet the needs of your population or your specific culture, as Adam so eloquently put it.
So next slide. And sorry, we're moving fast, but we definitely have a lot of content to cover. So as Dan and I said earlier, there's this sort of misnomer or misunderstanding out there that when I self-fund that I have this uncapped risk. Just not true if you set up your insurance appropriately. There are two basic types of insurance in a self-funded plan: specific stop loss coverage and aggregate stop loss coverage. And so specific stop loss coverage has to do with the claims associated with any one claimant. So Adam Bonsky, all the claims that have to do with me for a particular illness or a hospital stay or whatever it is. So typically what happens is I'm accepting some amount of risk as the employer, let's say the first $50,000 of cost for any claims that happen to Adam. And then the stop loss picks up over and above that 50,000. So it limits your risk to that first level deductible, if you will, at the employer level for that one claimant. So an employer might say, well, wait a minute, what happens if I have 10 employees or 20 employees, I have a bad year where I have a lot of employees get sick? Well, that's where aggregate coverage comes in. Aggregate coverage comes in and says, hey, we're going to protect you in the event that you have a lot of claimants that hit the spec deductible. Right? So you have two different types of coverages. Not every employer purchases aggregate coverage. Some of them don't see the value in it, but if you are new to self-funding, I would strongly suggest that you take out both a specific stop loss coverage policy and an aggregate stop loss coverage policy. So moving on to the next slide. Dan.
Yeah, this is a good one that kind of scratches me where I itch. And, you know, as a self-insured employer, we are subject to ERISA. And under ERISA, we are obliged to act in the best interest of our plan participants. So as part of that, the passage in 2021 of the Consolidated Appropriations Act really shone a brighter light on fiduciary responsibility for not only people that work on health plans, but board members, executives of companies that sponsor these plans. And it's really important that employers understand and remember that they do bear that responsibility for managing the cost and quality of the health plan as fiduciaries. Those of you that work or have partial responsibility over your retirement plan may recall back in the probably mid-2000s, retirement plans were subject to lawsuits based on the fees and investment options that were charged. And that really lowered costs for plan administration that ultimately benefited employers. The type of litigation that we saw back then, the mid-2000s, is coming to health plans in the same form. The attorneys are using the same playbook. They're coming after employers to ensure that they're meeting their fiduciary duty. There's some notable cases out there. Johnson & Johnson has one. Wells Fargo has one. So ultimately, if you haven't already done so, I really do recommend that you put processes in place to document your decision-making as it relates to healthcare, as it relates to what facilities your employees have access to, and just establishing a prudent process will go a long way towards protecting you in the event that you go through an audit from a regulatory body.
And there are also third-party administrators that will take on a co-fiduciary role with you as the employer. So that's something to look out for too, where you can share that responsibility with a third party who's got the expertise to help you make sure claims are paid and reasonably. So, all right. So we're going to start diving into cost containment now, the things that you can do in your health plans to drive down the cost of hospital claims and pharmaceutical claims. I'll say right up front here, these are just ideas for you to consider. Many of these are not good for all employers. It really just depends on your demographics, where you are in the country, what appetite for additional work you might have, what kind of resources you have on staff. So these are not, Dan and I are not here to say these are good for everybody. But they are things that you should be talking to your advisor about. These are concepts that you should be exploring if you want to start to work on bringing down the cost of care. And by the way, that doesn't mean the care gets worse. It just means you're paying a reasonable price for it. And we'll talk about how in many ways actually the care can improve through some of these measures. So let's dive into the first one. So the first one is reference-based pricing. And so some of you may have heard about reference-based pricing or maybe have tried it out, but this is a perfect example of something that's not for everyone. So we can go to the map on the next slide. what we're looking at here is in each of these states, how much hospitals charge as a percentage over their cost. So in Texas and Florida, in Nevada, it looks pretty bloody, right? I mean, Texas hospitals on average are charging almost 1,000% over their cost. So that's their charge master price. What we'll talk about in a minute is then the network, let's say United Healthcare, comes in and negotiates off of that charge master price. And in many cases, the network discount is 50%. So what I'll say is on the surface, that sounds good, but in actual fact, if you're starting at 1,000, then you're still at 500% over the hospital's cost. And so there's a lot, as you might imagine, given that there's a lot of room to negotiate in there. We also talked earlier about Medicare and how much plans are paying, employer plans are paying over what the same hospitals take for Medicare. So I think, Dan, as you pointed out, we want to make sure hospitals are successful, but we also want to make sure it's a reasonable fee that they're accepting for the services that they provide. And it has to be reasonable under ERISA because it's an ERISA plan. So anyway, find your state on here and you can see just how much the markup over cost is. We know this data because if a hospital accepts even just $1 from Medicare, then that hospital has to report all of their CPT codes and what they actually cost and what they charge for them to CMS, to the federal government. So we know what these numbers are. And we know what the discounts are at the carrier level. So let's go to the next slide. This is an example of what reference-based pricing looks like in action, if you will. Let's take a charge master price for a hospital service of $5,000. On the left-hand side, what you can see there is that the network negotiates from that charge master price and generally gets about a 50% discount. So for this service, let's call it an MRI at the hospital, the plan would pay $2,500. And I say the plan, it could be a combination of the employee in the plan, or if it's a high deductible, then the employee is paying that entire amount. So move over to the right-hand side, and reference-based pricing starts at the other side. It starts at the bottom and says, what's the cost of that service, of that MRI, let's say, or what does that hospital take from Medicare for that same service? And reference-based pricing provides a fair markup on top of that. So as you can see here, a good example with what a lot of RBP providers do is they'll either pay the cost of care plus 12% or Medicare plus 20%, whichever is higher. So again, this is an ERISA plan, and the fees and costs in an ERISA plan have to be reasonable. And so $336 for an MRI is a lot more reasonable than $2,500 for an MRI. And the hospital is still getting quite a sizable markup over what they accept from Medicare or what they actually pay for or have as cost for that service. So moving on to the next slide, you can get a real life example of an MRI in 3 different hospitals in Philadelphia. And I won't go through this entire chart because we're pressed a little bit for time, but as you can see here, the billed price at the hospital for these for an MRI is quite expensive, all the way up to almost $5,000. The average cost is a little over $100 or around that amount. Medicare pays $150, $170 for an MRI. At a discount off of that charge master rate, your plan is still paying, or your employee under their deductible is still paying $1,200, $1,900, $2,300 for that MRI. And in many cases, unfortunately, avoiding that care or not getting that image because it's too expensive. In an RBP plan, that same MRI is going to cost $191, $150, or $212. So there's a big difference there. And that starts with your employee calling the reference-based pricing vendor and saying, where should I get my MRI? And they will direct you to an MRI imaging center that will accept that payment. RBP is not for everyone. Some of the things that I think Dan and I would recommend, if you consider it, is that you pick the right vendor. There are a lot of folks out there that perform RBP services or reference-based pricing services, so pick the right vendor. I would recommend putting a physician's network in place because reference-based pricing plans have no network. So give your employees a physicians and specialist network to choose from for those first point of care services. Put a dual option in place. Allow the employees to choose between a network, a traditional, say, Cigna network option, or the reference-based pricing option, and they can choose with their wallet. And then most importantly, educate, educate, educate. I don't think Dan and I can stress this enough. If you're going to put RBP in place, you better have multiple enrollment meetings and explain to employees how reference-based pricing works, what to do before they go to the hospital, what to do if they get a balanced bill to avoid disruption in care.
And just to piggyback on that, Adam, I think you've covered it well. The reference-based benefits option is definitely a disruptive approach, and it will get your employees' attention. We've looked at it for the last 2 or 3 years. I think one of the other things that you need to think about if you're going to go down that road is to have some advocates, patient advocates, to assist your employees, have some kind of concierge service to allow them to go to the right place. To Adam's example, where should I get my MRI? Where should I have this surgery done? Hand holding is important, especially in our exceedingly complex healthcare system.
And some employers thrive on this type of a plan, and that might be the hospitals in their area are more collaborative, if you will. And some employers really struggle with it. So it's something to evaluate with your advisor. So next slide, I think Dan, over to you on high performance networks.
Yeah, absolutely. High performance networks have begun getting a lot of attention the last 4 or 5 years. And to me, conceptually, I'm a big fan of high performance networks. And the way I think of them is, say you're contracted with a Blues or a Cigna or United or an Aetna, and you want your employees using the highest value providers in those networks. Your TPAs can curate those networks for you. Generally, they have those available for you to choose. And conceptually, I think they're a great idea. One of the things that I've seen over my years in looking at these high performance networks is that you have to be careful to make sure the juice is worth the squeeze, right? Because it can be disruptive. If you remove some provider networks or hospital systems from your in-network list of providers, you can alienate some of your employees. You may upset some of your plan participants, and you have to make sure that the savings that you could potentially gain and the outcomes and the value that you're going to achieve by putting that narrow network in provides the savings that you would expect, right? So that's an important piece for me.
Yeah, I would just add that most of the way networks are created is sort of more of like the Statue of Liberty approach, bring them all in, right? And that can be difficult because your employees don't necessarily know which ones are high quality, which ones are a reasonable price. So it's just let everybody in so that all the employees can be happy. But that can add to a lot of poor outcomes and really expensive procedures. So high performance networks, that's saying more, hey, let's narrow this down and pick those, for example, hospitals that are top performing at a reasonable price and guide our employees in that direction. And maybe even through that steerage, give them some incentives, some money off of their deductible if they go to those high performance or to those high quality providers in the high performance network.
You've also got centers of excellence that can kind of fall under this umbrella too, where you're providing employees with that financial incentive in the form of a lower deductible or some kind of stipend to use the facilities that are best able to provide the services that you need.
All right, so next slide.
Direct contracts are another way to go. So think of it this way: as an employer, you can go to a health system in your area and work out a direct contract with them that may be lower than you're seeing with your contracts through your carrier or your TPA. And that can generate some significant savings. You can lower costs, cut out some of the middlemen. You're going to have price transparency. I know a health system here in the Baton Rouge market is doing direct contracts for 200% of Medicare and below. That's great. You get higher quality of care. Some of those direct contracts will lead to employees and patients getting something like white glove treatment when they go to your partner of choice in a market. Customized terms are an important thing. You know, tailor the agreements to include bundles when you're going through medical care. If you can get bundled payment arrangements based on an episode of care, that's going to be less costly than in fee-for-service, where the plan is dinged for every bit of care that a patient receives. Partnerships, and I view this kind of as a community building opportunity too. You know, you build these partnerships locally with health systems and hospitals that you trust, and that's a real big win, and it's a good member experience. Now, the one drawback with direct contracting is that you need to find a good TPA that can administer that contract for you. The carriers won't do that, because generally they won't do that because the product that they sell is their network, right? And it is their discount. So you would have to find a TPA that's able to do that. Direct contracts come in many different forms, as I'll discuss a little bit later. Turner has some direct contracts in 4 different geographic regions that are a little bit different than you may be thinking of. But Adam, what are your thoughts on direct contracts?
I think the most important thing I would leave folks with is when you're deciding on what TPA to work with or what program to work with for your self-funded plan, that the partners that are involved, particularly as Dan said, the third-party administrator, that they have the ability and in a relatively short amount of time to help you in setting up these direct contracts. They should have the expertise to support you there. You're not alone in it. So they, in conjunction with your advisor, should be able to find have the ability to reach out to the local hospitals and set up direct contracts. And to the extent, again, your employees go to those providers, give them some incentive in reduction in out-of-pocket costs. So next slide. And sorry if we're going to keep flipping through. We are going to go a little over. So if you have to leave at the bottom of the hour here, please feel free to do so. This will be recorded, and Dan and I are just going to keep going because there's a lot of great stuff to keep covering. So bundled cash pay platforms. So I'm not sure if any of you have experienced this, but a lot of providers like cash. And if you show up and pay cash, oftentimes that cash pay price is even lower than Medicare, what that same provider accepts from Medicare. So the struggle is if you're going to pay cash at a provider and you have a network plan, it's not going to count towards your deductible. Right? Your out of pocket will be nice and low at the doctor's office, but it's not going to get credited against your deductible in your plan. So if you're in a self-funded plan, however, you can set up your self-funded plan such that your employees have access to bundled cash pay providers. And so what you'll have is basically a platform, let's call it a portal, where your employees or your TPA can log in and find surgery centers and imaging and lab work and mental health and PT and Chiro and all kinds of cash pay options, providers that will take cash pay on the spot, right? Surgery centers are perhaps the biggest cost-saving opportunity for you in your health plan, bundled surgery centers. So I'm not sure if anybody here has had a surgery, but what does that look like? You get 7 different bills from all these different providers, right? You get the surgeon's bill, the anesthesiologist bill, you get the facility bill, you get billed for the hardware and supplies, you get all these different bills, right? And you can't make heads or tails, and it all adds up to a lot of money. And so in a bundled surgery center approach, it's kind of like the Happy Meal, right? I show up and I know what's included in the surgery and how much I pay for it. And what's great about bundled surgery centers, other than the fully disclosed price up front, is that they do a lot of volume. So they're really good at it. Their facilities are cleaner than hospitals, so there's less cross-contamination. In some cases, your plan could even pay the travel costs for your employee to go to that bundled surgery center to get the surgery done there. because the cost is going to be a fraction of, sometimes a third of what it would cost to get that same knee replacement, let's say, done in a hospital. 15,000 versus 45,000, right? So this can be a huge cost savings. And again, something that you want to drive your employees to by reducing their out-of-pocket when they go to a bundled surgery center. So there's a clear trend here to go towards more cash pay models. So go ahead, Dan.
Yeah,
sorry.
Real quick on the bundled approach. Quite often you'll have providers that do these surgical procedures. In Adam's example, the knee replacement, they'll take back-end risk on the procedure, and they'll, you'll pay $15,000 for the bundle. And if there are complications, if they have to go in and repair the joint, or there's an infection of some sort, they take the risk for that. So the bundled payment covers the entire episode of care, that's really hard to beat, because in today's world, in the fee-for-service world, a plan would still be, they'd be dinged for the 45,000, and then they'd be dinged for a readmission and then another surgery. So it could get exceedingly expensive very quickly.
Yeah, especially with complications, cross-contamination, any of those things that can happen at a hospital. So another thing to talk about with your advisor or whoever your TPA is, cash pay platforms. Next slide, direct and virtual primary care. So this is one of my favorites because, to me, the best way to manage claims is to not have them happen in the first place. And the better job we do of taking care of our employees, the less likely they're going to need drugs or to go to the hospital. So the direct primary care phenomenon, if you will, has been happening over the last 2 decades. It's basically where a physician is tired of the insurance model, where they have to see 20 patients a day for 9 minutes each. They've got 20 people in the back office filling out claims paperwork. They're getting claims paid in 90 or 180 days. They're constantly having to bill and rebill. It's a disaster for a lot of primary care physicians. So they say, I'm out. I'm no longer going to take insurance. I'm going to charge a membership to belong to my practice. And I'm going to have a smaller patient panel. I'm going to see people every day for an hour at a time. I'm going to cover all their risk factors. I'm going to be their real doctor. And I'm not going to have all these people in the back office filling out claims paperwork. So direct primary care, I think, is one of the biggest and most important innovations in the last several years. It's something to look at for your employees, where you can cost share, you can pay for all of it. It's a membership fee. So you're paying a per member per month fee for your employee to belong to that doctor's practice. What we have found is that in the underwriting, the decrement that you get in the underwriting is anywhere from 18 to 20%. So that there's a lot of savings to be gained in the fixed cost for your plan if you offer and pay for this type of service for your employees. Like I said, best cost containment you can do is not needing drugs or hospital in the first place, right? Dan, I think you've actually piloted direct primary care at one or more of your divisions.
We have, yes. And I'm a big believer in advanced primary care and giving people access to primary care. One of the things that we struggle with in the construction business is that a lot of our employees will travel for work. So we may have, in Houston, for example, that's where we've had a successful pilot of over 3,200 participants with access to an advanced primary care facility in their region. We have partnered with a vendor there who has 20-something, 25, 30 clinics in the Metro Houston region, which is sprawling, as most of you know. And our employees and their family members can use those clinics for primary care, urgent care, preventive care, shots, flu shots, vaccines, basic generic medications, and some basic imaging at no cost. And Turner's paying a flat capitated amount on a monthly basis for those people. And it's been extremely beneficial we are now almost 2 years into it in that market. And comparing 2025 to 2024 costs through the end of, this would have been August, end of August, we're at almost 20% savings in medical claims, independent of the facility that is providing this advanced primary care. But that's inclusive of the charges that we're paying for that. So it can really make a difference, especially in our business. Access is everything. People work long hours. They can't get in to see a primary care doctor between 8 and 5. But if you've got some extended hours and weekend hours where they can have their preventive care done, it's a real benefit. So I'm a big supporter, big believer in this.
I've been a member of a DPC for I think almost 5 years now, and it's back to having a real doctor, right? I have them on chat. I can text them anytime. I see them for an hour every time I go. It's so different.
Yep.
So we'll keep moving. Next slide, we're going to jump into the pharmaceutical side of the cost savings picture. Again, 7 to 10% of the medications your employees are taking are driving 90% of the cost. So it's really important to look at how you're sourcing medications. So these are the different types of sourcing we're going to talk about here. So let's just jump right into the next slide. Dan, I think you're going to kick us off here.
Yeah, patients assistance programs. So those are most simple when considering uninsured or underinsured, and that manufacturers assist with the patient receiving drugs that are beyond their means from a financial perspective. Within an employer-sponsored plan, it's a little bit more complicated. Generally, you see an employer produce a coupon or a card when filling the drug, which will pay all or a portion of the cost of that medication. And usually it's all for a period of time until you meet a certain cost threshold, at which point the patient certainly benefits, and then the employer benefits in the form of not having to absorb the cost of that medication. Copay accumulator programs are also very popular too, but there can be some blowback on plan sponsors there as once that assistance is exhausted, a patient can be left holding the bag on costs. So those are a couple of the insights that I have on some of these prescription strategies.
So we're going to talk a little more deeply about patient assistance programs and international pharmacies, because those are the two biggest, as you can see with the dollar signs represented there, the two biggest cost savings areas. And patient assistance programs, or PAPs, and international sourcing are not generally available through big insurance, if you will. So they're really things that become more available to you through a partially self-funded plan and access to a more innovative PBMs, if you will. So next slide on PAP. Dan, obviously you're taking advantage of PAP at Turner Industries. This here is an example of what the difference can be in terms of what you might pay for that, or you or your employee might pay for that drug versus what you would pay under a PAP, which is typically either completely paid for or a majority of the drug cost is paid for. So there's usually some type of administrative fee for filling out the paperwork, but after that, the medication itself is pretty low cost. I've got a few stats here, Dan. Individuals making all the way up to $48,000 a year can receive, be eligible to receive free or subsidized pharmaceuticals, right? And that's about 400% of the federal poverty line. Couples that make up to $65,000 as a couple or as a family can be eligible for full payment or a majority of the payment of the cost of the drug. If you're looking for more information on PAPs, you can go directly to the manufacturer's website. Or I found a site Dan and I talked about a while ago called needymeds.org. And you can look up any drug there and see if the manufacturer has a patient assistance program in place for that drug. And it's not necessarily low income. I would say it's lower income this can become available to those folks in those salary ranges I mentioned earlier. Anything else you can think of, Dan? I mean, obviously looking at your employee database and what everybody makes can be a starting point, right?
Yeah, absolutely. And you just made a great point, Adam, in that income really isn't a factor. I know of senior vice presidents who are accessing PAP discounts on high cost drugs. And it really, I mean, it makes a difference in their cash flow from a month-to-month basis. But where it really makes a bigger difference is for the folks that are truly maybe lower income that have trouble making ends meet. So yeah, having your data and being able to look through the information, kind of the way that this is laid out, the slide is laid out, is going to be important for you and your consultant to look at and see what opportunities are in front of you.
Yeah, the drug manufacturers are required by law to set aside funds for lower income individuals. So the money's there. It's just knowing that you can tap into it. On the next slide, we'll talk briefly about international sourcing. As I mentioned at the top of the call, we in the US are paying sometimes as much as 8 times for the same medication that other countries like Canada and the UK and India are paying. So there's a huge disparity there. So you're seeing plans starting to look at options for sourcing drugs internationally and finding a pretty significant cost savings, as you might imagine. And on this slide, you can see what that cost savings looks like. And to the extent your employee is open to receiving the medications through international sourcing, then don't charge your employee anything out of pocket, right? Incentivize them to receive that in the mail internationally and not have to pay anything out of their own pocket because the plan is saving so much money on the medication. On the next slide, you'll get an example of what I would call a pharmaceutical reprice. So when you're working with a PBM and maybe considering a new PBM, you can do what's called a reprice. You can ask for the PBM that you're considering to show you how much they would have paid for the same drugs if they were the PBM in place last year. And so this is a reprice done for a company that was in Tennessee with about 200 employees, and they were working with Blue Cross Blue Shield of Tennessee. And I'll just point out the bottom line here. This company, through getting that reprice and moving away from Blue Cross Blue Shield of Tennessee, was going to save almost $650,000 in drug costs in the following year. So it's a massive opportunity for you to find savings. And it's as simple as saying, hey, wherever I'm going, wherever I'm considering going from where I'm at, show me how much better you're going to do on these RX claims than the prior PBM did. And then have them put some skin in the game. Have them put their fees at risk if they don't get those savings that they tell you they're going to get, right? Have them put their money where their mouth is, if you will. So the savings aren't always this dramatic. Obviously, if you have a lot of employees that are eligible for PAP, for patient assistance programs, or if you have a lot of medications that can be sourced internationally, then you can start to see these types of savings in the hundreds of thousands. Okay, member advocacy and experience. So as I said at the top of the call, we wanted to talk about improving the care and the service your employees receive while finding them lower cost, high quality, lower cost options, while also finding them more money to help cover their out-of-pocket expense as well. So care navigation is perhaps the most important thing I think you should make sure you have in place. And Dan, you're going to, I think, touch on this a little bit.
Yeah, care navigation is something that we definitely have experience on with, and I did touch on it when we were talking about reference-based benefit programs. For me, like I mentioned earlier, our healthcare system is really complicated, and for employees of Turner Industries, having assistance in understanding how to use that care is really important. And we've partnered with health systems in Baton Rouge, Lake Charles, Louisiana, Beaumont, Houston, Corpus Christi, and Paris, Texas, to have a nurse go to our job sites, our offices and job sites, to engage one-on-one with employees to help them with medical questions, to help them manage chronic disease, to point them to a GI doctor to do a colonoscopy if they are due for one, or in a lot of instances, they've never had one. And, for us, face-to-face is important. That's kind of how we do business. And our employees definitely appreciate someone sitting across the desk from them, telling them, look, I can get you in at a orthopedic doctor this afternoon because I've got a relationship with that office, or I am an employee of that health system, can really be beneficial. And what we've seen we've had this Navigator program in place since 2009. It saves the plan millions of dollars a year when you track the people that participate in the health coaching program and the navigation program. It helps steer care to the facilities that we have partnerships with. And think about this as a direct contract. It's a different way to do direct contracts. And as long as you're partnering with facilities that are fairly value minded, it's going to be a win-win for everybody. So I'm a big believer in care navigation, and that kind of thing. As a lay person, I can't tell my employees where to go for care. They trust someone who's an RN or a PA or has some kind of clinical expertise, and it's really been invaluable to us.
I mean, you can put all the cost containment services in place you can think of, but if you don't have somebody navigating your employees through how to use them, how and when to use them, then you're not going to get the full efficacy, right?
Right.
So next slide. And I think you might advance one after that. Yep, you can move to the next one. So maternity advocacy is another key area. Some of you may have heard of high cost claimants coming from NICU experiences, so from babies who are born prematurely. So the average, I think, NICU full cost can be anywhere in the $150,000 to $160,000 range. NICUs are generally, depending on the hospital, anywhere from $3,000 a day to $60,000 a day, depending on the hospital. So NICUs can get into the millions pretty quickly if it's a really bad NICU incident, if you will. So what's really important here is to make sure that any of either your employees or their spouses who are going through a pregnancy, that they are taking advantage of the maternity care option in your plan, and not only sort of listening to, if you will, what the nutrition plan, what the exercise plan, what are the things they should do through their pregnancy are, but also elevating concerns quickly, because most NICUs are avoidable. And so I can't stress this enough. This is something to advertise and market to your employees to take advantage of, to the extent your plan has a maternity advocacy program, so that you can prevent those NICUs from happening that cost so much. There's a very popular maternity advocacy program called OUMA, O-U-M-A, and Marty McCary, who's the current FDA leader, is the one who started OUMA. So this is money well spent, I'll just say. Next slide talks about financial advocacy. So there's this little known section of the IRS code called 501R. It's similar to the patient assistance programs we talked about earlier, except instead of the government requiring pharmaceutical companies to put money aside for lower income, it says nonprofit hospitals are required to put money aside for the care associated with lower income individuals. And the for-profit hospitals tend to follow suit. So on the next slide, even employees that make up to $100,000 as a household a year can be eligible for relief against their out-of-pocket costs, against their deductibles and coinsurance. So, and this is an example of hospitals in Florida, but these funds are available through hospitals across the country. And so it's just knowing that 501R is a real thing. The hospitals set the money aside, but they make it pretty hard to get at that money. And so you need typically vendors to help you fill out the forms to obtain that money for your employees who would be eligible for those funds. So we're short on time. I wish we could dive in deeper. We'll jump into proactive eligibility management. And Dan, I think you have some comments here.
I do. Yeah, I'll try and keep it short. I know we've run long. Effectively managing your plan's eligibility is crucial, and it's really simple blocking and tackling from the benefits administration perspective. My team and I conduct a dependent audit every year to ensure that the people on our plans are eligible. We do a front-end check before we enroll people on our plan to ensure that we have a copy of a birth certificate or a marriage certificate. There are a lot of third-party vendors operating in this space as well. Some of the other things to think about with your eligibility is whether or not you want to impose a surcharge to cover spouses on your plan if they have access to coverage elsewhere. Are you collecting all of the premium dollars that you expect to collect? Is there leakage, financial leakage from your plan, whether due to people being out on medical leave, being on a leave of absence, just a personal leave of absence? Are you collecting the dollars that you expect to collect? And it's a matter of, the decision of eliminating risk or managing it, right? So if you're going to cover your spouses, if you're going to cover spouses on your plan, they tend to drive costs in our plan experience far more than employees or dependent children do. You just have to be sure to plan for it financially and make sure that you're covering your bases in terms of eligibility. Any thoughts there, Adam?
Yeah, there's a lot of bullets here that I would suggest you all read so that you can get a sense of some of the ways that you can design your plan to handle spouses in your plan the most effective way that works for your business. Some people write their plans to say if your spouse has coverage through their employer, then they're not eligible for your plan. And that's a pretty hard line to take, but some employers are going down that route, or they're putting opt-out bonuses in place for high tenured employees that say, hey, we'll give you this bonus if you take Medicare or your spouse's plan instead of our plan. So there are lots of ways to help manage eligibility, because as Dan pointed out, there's risk that you have to manage and there's risk that you can remove, right? And so the best risk is the risk you can remove from your plan and not weigh down the plan and increase the cost for you and all of your workers. There's also a spousal incentive health reimbursement arrangement that can be looked into, where you can put pre-tax money away in an HRA for employees who do take their spouse's plan, but still get some benefit from you. And so there's some incentive there for them to take that spousal plan. Anything else, Dan?
No, I think we should jump to the next slide.
Yeah, we can jump into Samaritan Fund. We're in the home stretch, folks, I promise. So the Samaritan Fund is a really interesting, newer, I'll call it another phenomenon. It's really a special program that works with employer plans to take those hard cases. It's usually, depending on the size of your company, it's that 1 or 2% of your employees that are in really bad shape, whether it's organ transplants, super high cost medications, really difficult disabilities, really difficult cancers or terminal cancers. The Samaritan Fund, through an application process, will look at taking that employee and having them enroll in their own individual plan. They will pay the premiums. They'll pay, it sounds too good to be true, but they'll pay the premiums, the out-of-pocket costs. They'll manage the employee through their care, and that employee is off of your plan. Right? And so it's actually a better model for that employee because they're going through such a tough time, and it's hard for an employer plan many times to help employees through that difficult of a situation. Now, the Samaritan Fund does make money. They charge a fee for this type of service, but it usually is quite a bit smaller. We're talking claimants here that are $500,000, $1 million in claims, and so their fee is dwarfed by the amount of claims that pile up for these very difficult cases. So the Samaritan Fund, especially if you've got a couple of folks that are really causing your plan a lot of claims, is something worth looking into. So, and we can provide information on it. You can Google it up. They provide webinars every other week. You can learn more about how the Samaritan Fund may work for you and your employees who are having challenging health conditions. Last but not least, many of you probably have heard about medical stop-loss captives, which on the next slide, we provide you some summary there on what captives look like. They allow you to reduce insurance fees because some of the fees that the insurance company would normally take are actually borne by the captive. You can share risk with similarly minded construction companies. You can build a program of all the cost containment that you and your fellow captive members want. The exposure is capped both by your own specific and aggregate insurance coverage, but also by the captive. So there's a lot to like about captives, but they're not for everyone, and not all captives are going to be able to let you in. In many cases, it depends on how your claims are running. But the ABC has its own captive for its members, something to check out possibly if you have around 50 employees or more enrolled on your health plan. We won't dive into on the next slide into the real nitty gritty on how captives work, but if you're curious about it, let Dan or me know, and we're happy to hop on a call and explain more about how captives work. And last but not least, ICHRAs, individual coverage health reimbursement arrangements. They've been around for many years now. Dan and I haven't seen as many employers, especially in construction, implement these types of plans. We're a little surprised actually, because I think there's a lot to like about them in terms of managing risk. It's essentially a plan where you provide money pre-tax to the employee to buy their own individual health plan, and the employee can also contribute to that HRA pre-tax for their portion of the premium, and all you're doing is managing a reimbursement program. It's much like what happened with pension plans years ago. Pension plans went from defined benefit to a defined contribution approach. So ICHRAs allow you to go from a defined benefit employer health plan approach to a defined contribution approach, where you give your employees a set amount of money on a pre-tax basis, and they buy their own individual coverage with a navigator, usually with care navigation as well. So it can look a lot like an employer health plan, but they're on their own individual insurance policies. And some states are way better around ICHRAs than others. If you're in the Midwest, in Ohio, Indiana, Illinois, Kentucky, those are states that have very competitive individual rates compared to group rates. So something to consider, and you can carve it up. You can offer the ICHRA to 11 different classes, salaried and hourly, union and non-union. There's all sorts of ways you can easily Google up 11 classes, and you can set up just some of your employees on an ICHRA, and the rest can be on an employer traditional plan. So anyway, we are way past time. Thank you for your patience and hanging around with us. There probably are some questions, so let's maybe Brian take a few of those, and then we'll let people out of healthcare jail. So.
Yeah, wow, that is it's a lot of information. I went through a shoulder issue this year, and just I had a billing company for the imaging facility. I had the imaging facility, and I had MedMutual all on the phone, and nobody could tell me what the MRI was going to cost. I was trying to decide whether I go through insurance and end up paying more out of pocket on my high deductible than if I just pay cash directly to the facility. And it's so frustrating. So
frustrating, right? That's where that care navigation that we talked about earlier comes into place, is to make sure that that's available to your employees so that they can start with the care navigation team, and then they know where they're going. They'll set the appointment for you in many cases. They'll tell you what it's going to cost and how it's going to get paid for. So that's why that piece is so important, is to make it a simple experience for your employees, meanwhile guiding them to the highest quality, lowest cost options.
Yeah, no kidding. I wish we had that. Maybe we do. Maybe I just don't know about it.
You might. In many cases, it's available, just employees maybe aren't aware of it.
Yeah,
Brian, you're frustrating we benefits people. That means you're not reading your materials. Make sure you look at your open enrollment material.
There's so many materials to read.
That's true. That's true. Yes,
it's crazy. True. Well, we definitely do have questions, and we can take a few. I know we're way over time here, but it's been a great conversation. I've learned a lot. Hopefully everyone still on here and watching the recording has as well. So let's try and take some easy ones, right? Is there a list of TPAs who offer co-fiduciary?
I don't have a list, but I know of a few. So Imagine 360 is one that we use. They're in Dallas, Texas, and they take a co-fiduciary role over claims, particularly when and if an employer uses that reference-based pricing model that we talked about earlier. But I don't have a list. Dan, I don't know if you have a couple off the top of your head, but it is a question that you should absolutely ask of your TPA or any TPA that you're considering, if they will take on that role.
What about a website to check for PAP options?
So you can go directly to the manufacturer's website. that's a good place to start. And then a couple weeks ago, I was referred to a website. It's Needy, Needy meds, needymeds.com, I think it is. I can double check it. But again, directly to the manufacturer's website or through needymeds.com. And you can just type in the name of the medication, and it'll let you know if the manufacturer has a patient assistance program available. And I'm looking to double check that website, but go ahead with the next question, and I'll see if I can find it.
I would also chime in real quick, Brian, that patients can also ask their doctors about these programs too. Doctors will generally have some good insight on what PAP programs are available.
Exactly in the 9 minutes that we get with our doctor, we'll ask that question.
Yeah. So it is needymeds.org.
Needymeds.org.
Needymeds.org. Yep. So yeah, that's just nice because they provide kind of a roll-up where you can just do a search on the drug and see what the manufacturer has, and then you can link off to the manufacturer website from there, or go just directly to the manufacturer. As Dan said, talk to your doctor.
Yeah. This next one is interesting. I think it affects a lot of our client base here. Dan, maybe you can speak to it as well. The question is, how well do these plans work when you have employees that are scattered? They reside in different areas and might need to contract with providers in different areas.
Tricky. As it relates to, we'll use my direct primary care example from earlier as a place to start. We're doing it in Houston because there's a vendor there that's really good at it, and that was an easy place for us to start. We'd love to be able to duplicate that across our footprint across the US. There just are not vendors doing these things in every pocket where we operate. Some of these places are fairly remote. However, I did learn yesterday of an entity that is known as Aligned Marketplace that provides an aggregated approach for advanced primary care and direct primary care nationally, which is neat. So now, Brian, I know I was very specific in that answer, but you're right. For employers that have people scattered across the US and sometimes internationally, it may require some specified options for different pockets of your population that can really, it can increase the administrative burden on your staff. But it can also pay dividends.
Sure. It's almost like you need regional HR staff members to just manage the health care plans in those pockets.
Right.
It's crazy. Looks like we have two more that I can see here. If you're a large employer for ACA purposes and have to provide insurance, can you also offer the ICHRA?
That's a great question. So the ICHRA absolutely can be ACA compliant. So if you think about what makes a plan ACA compliant, number one, you have to make the offer of coverage. And so the ICHRA constitutes an offer. Then it has to be both minimum value and affordable, right? And so the plans that you buy through the exchanges with an ICHRA are all minimum value. And you work with your third-party administrator, the ICHRA administrator, who we can give you some names of companies that do this quite well. They can run the figures for you to show you how much you would need to contribute to make the plans in the market affordable. So you can absolutely structure the ICHRA to be ACA compliant if you're a large employer. The only trick will be to figure out how much you'll need to contribute to those HRAs to make the individual plans they would purchase in your area affordable.
Great. Last question. Who helps navigate the 501R programs? ABC Insurance Trust?
That's a great question. So that is something we outsource. It's pretty highly specialized. There's a company in Texas called Upland Advisors who does a very good job of this, has been doing this for many years now. But they're not the only ones out there. You can tap into, you can search it up, use AI and basically search on 501R section of the IRS code and ask about administrators who will help you as an employer fill out the paperwork to obtain those funds for your employees.
That's great.
Or I know the folks at Upland Advisors quite well, and they'd be happy to hop on a call and talk to you about their service and how it works.
It's awesome.
I don't get paid anything for doing that advertisement. I just know they do a good job.
Well, everyone, we have Adam and we have Dan. Their contact information is here on this page. Guys, I want to thank you both for taking the time to put together this presentation and for taking the time to sit with us throughout this entire webinar. A lot of really great information in a really challenging time in healthcare, for sure. You know, for many of us who are fortunate to be healthy, we don't have to have all this exposure with hospitals and doctors and everything. But man, when it happens, it becomes messy very quickly. So this was very informative for me. I hope it was informative for everybody who attended. We still have a few, 34, looks like, still hanging out with us today. So thank you guys for running the duration. And until next time, I want to thank you all for attending. Again, Dan and Adam, thanks for presenting.
Yeah, I'll just say, Brian, hey, everybody, you know, Dan and I are passionate about this. We want to help, right? And so feel free to email us with any questions you have, and we'll do our best to guide you from there.
That's great. All right, everybody, until our next webinar, have a great day and go Guardians.
Go Guardians.
Side of the fence around.